Hello, in this video lecture, we'll be continuing our discussion on coding diseases of the cardiovascular system. We'll continue our discussion on chronic kidney disease, get into heart failure, and other topics. And again, hypertensive heart and chronic kidney disease, I-13, any heart disease that's due to hypertension present with chronic kidney disease and hypertension. The codes exist for both hypertension and chronic kidney disease with and without heart failure. Same types of stages, stages 1 through 4, with stage 5 being end stage renal disease. And of course, we'd want to use the additional codes to specify the type, the stage of chronic kidney disease, and the type of heart failure. Secondary hypertension is hypertension that's due to another disease. In this case, we'd code both the cause and the hypertension itself. So we would need two codes, one for the underlying condition that causes it, and one for I-15, the secondary hypertension. Hypertensive crisis, I-16, is also described as hypertensive urgency or hypertensive emergency, and these should be coded with another code that identifies a type of hypertensive disease. And depending on the circumstances, either the I-10 or the I-15 or the I-16 codes may be sequenced first. Again, going back to our definition of what is the principal diagnosis, it's the reason the patient was admitted after study. Ischemic heart disease has combination codes. And basically, it means that the heart isn't getting enough blood. The codes show where the problem is, right? So these are codes that include both the atherosclerotic heart disease with angina and gets into the I-25 codes. I-25 category codes talk about the location of the coronary artery disease, such as a native vessel, the bypass graft, the type of angina as being stable or unstable with the spasm, and so on. You may want to review figure 12.1 in your text to talk about that discusses the coronary arteries. And again, we talked about code category I-20, angina, the chest pain due to not getting enough blood to the heart. And there are two types, stable and unstable. Unstable is chest pain that happens at rest, and this is considered serious, may result in hospital care. This can also be known as crescendo or pre-infarction angina or intermediate coronary syndrome. And these are these prolonged episodes of angina that occurs at rest and requires hospitalization to rule out a myocardial infarction. Angina pectoris is chest pain from reduced blood flow. This may result in pain going down the left arm and is helped by rest or medicine. Code category I-20 identifies the forms of angina pectoris. Subcategory I-25.1 includes a combination code for atherosclerotic heart disease of a native coronary artery with angina pectoris. Subcategory I-25.7 includes a combination code for the atherosclerosis of a coronary artery bypass graft and coronary artery of a transplanted heart with angina pectoris. And we don't, in this case, code an additional code for the angina. We use the combination code unless the angina is from something else. A causal relationship is assumed when a patient has both atherosclerosis and angina pectoris, unless the documentation indicates that the angina is due to something else. So we only use the combination codes. The coder needs to know the location of the coronary arteriosclerosis in the heart and the type of angina. Now back to acute myocardial infarctions, or AMIs, for a moment. A heart attack basically is sudden and damages the heart. And again, frequently we have people who have more than one heart attack. We use a code from the code category I-21 if it happened within 4 weeks. Codes from I-21.A1 through I-21.B are for the other types of myocardial infarctions. Type 2 myocardial infarctions are due to the demand ischemia or ischemic imbalance. So there's a note that says code also to identify the underlying code if known and applicable. Now, this is an important section here dealing with I-21.A1 through I-21.B, and then we'll get into I-22. So pay attention to this next set of slides. These codes cover the meaning the I-21A1 through I-21B for other types of myocardial infarction. These are the type 3, type 4, and type 5. And there's a section on Canvas where you can go and click on the links and learn more about exactly what those types of acute myocardial infarctions are. And I'd encourage you to read that. You'll also see in the tabular to see the code first and code also notes under code category I-21.A9. I-22 is a very important code, and the definition of this is one that occurs within 4 weeks of the first myocardial infarction. We don't assign any code I-20, an I-22 code, if you will, for a subsequent MI other than a type 1 or unspecified. So it's got to be either a type 1 or an unspecified type and within 4 weeks. Otherwise, we don't assign an I-22 code. If we have a subsequent AMI within 4 weeks of the first AMI, and it's a type 2, type 4, type 5, we would code that to the I-21.A1 and I-21.A9. Codes from I-22 have to be used with codes from I-21. Since we have a subsequent type 1 or unspecified STEMI or non-STEMI and it occurs within 4 weeks of the original MI, both are coded because the original is still acute and has a duration of onset of happening within 4 weeks of the first one. Now for the sequencing. It is entirely possible that somebody will come to the hospital with a first type of a type 1 STEMI and develops a second STEMI while they're in the hospital. In this case, the principal diagnosis, meaning the reason for the admission after study, the I-21 would be coded first and then followed by the I-22 code. Let's say the patient gets discharged and comes back within 4 weeks of the original STEMI for treatment of a subsequent type 1. Well, the reason for admission after study would be the second AMI. So in this case, the I-22 would be coded first and the I-21 would be an additional code. In other words, it's still present, still being evaluated, treated, so we would still code it, but the reason for admission would be the first one. If a subsequent myocardial infarction of one type occurs within 4 weeks of myocardial infarction of a different type, you would assign the appropriate codes from category I-21 to identify each type. We would not assign a code from I-22. Codes from I-22, again, should only be assigned if the initial and subsequent myocardial infarctions are type 1 or unspecified. And that's all I have for you. Come back for our next video lecture where we'll continue our discussion of coding cardiovascular disease. Bye now.